I can just hop
Okay,
in
great.
if that works.
What was that again?
I can just hop in if that works.
Yeah. So let me just give you a quick introduction. So thank you everyone for joining. I started the recording. Welcome to our last AME seminar of the semester. We have Devin giving a talk on brain simulation and multi-contrast MRI today. And Devin, take it away.
Yeah, sure. Good morning, everyone. First of all, thank you for being here, for having me, for giving me a platform to do one of my favorite things, which is yap about my research. Um, what I'm going to be talking about today is pretty much my thesis project. And I wouldn't necessarily call this AI research. I would call it more like medical imaging research that uses machine learning tools, which I think is like a good application for AI in medical imaging. Um, I right now I'm at University of California, San Francisco, and I'm at a joint program with UC Berkeley. I work with Dr. Melanie Morrison, who should be here briefly, and we work within the radiology lab. I'm going to start with just a really quick introduction of myself and how I've kind of gotten where I am. I'm in my third year of the PhD. I probably have about a year left. Um, like I said, I'm in a bioengineering program, and I always like to joke that I've actually never taken a biology or an engineering class ever in my whole academic career. And so I think it's kind of funny that pretty soon I'm going to have a doctorate in bioengineering. Um, but it's definitely not been a straightforward path. So I think it's fun to talk about it a little bit. Um, I'm from LA, Los Angeles, California. I grew up there. I had no idea what I wanted to do for a long time. So after high school, I like traveled around. I worked a lot of really weird jobs. At one point, I was a pigeon breeder and seller. I traveled around and worked on movies and TV shows, and I just like I couldn't figure out what I wanted to do. And what there was like a turning point in my life is when I got a job at Griffith Observatory. And I don't know if you guys know about it, but it's a really famous like space and science museum in LA. And I was hired as a museum guide, and so my role was to give lectures, give tours, answer questions, help people look through telescopes. It was really fun. I was there for many years. My bosses there convinced me that I should go to college, which kind of hadn't been on my radar, to do. And so I ended up going to the University of Hawaii, and I studied astrophysics. One of my biggest claims to fame is that this is still the homepage for the physics department in Hawaii. It's some 7 years later. I think they lost the password, so they can't go in and change this. So this might be here forever. My research was primarily focused on like particle astrophysics. I did a lot of neutrino work, some dark matter stuff. I got really into detectors, and then after graduating, I got really into particle accelerators and like cyclotrons. This is me at CERN at the Large Hadron Collider in Switzerland. I ended up getting a job at MIT where I was helping them design and build really high-powered cyclotrons for neutrino work. This is where I first learned about the medical applications of physics, making medical isotopes for therapy or for imaging. And I got really hooked on the idea of using my physics background in medicine to like help people. And then at the same time, another big thing was happening in the world, which was COVID. The pandemic was starting. And so I actually moved to Oregon, which is where I am now, for the holidays, where my mom lives. And I joined a master's program in medical physics. And I specialized in diagnostic imaging. Um, and a lot of my research, actually, all of my master's research was in nuclear medicine. I was studying the effects of methamphetamine use disorder on the brain, using PET imaging. And then, kind of at the same time, because I can never just relax and do one thing, I got a full-time job at OHSU in the occupational health department as a biostatistician. They were doing this really big study looking at the immune response to both the vaccines and to infection with COVID. And we had 2,500 participants. I got actually licensed as a phlebotomist, and I was doing all of our patient blood draws. You know, they would come in every 3 months. So I did thousands of blood draws. I was actually I got certification to administer the vaccine. So I was doing all of our vaccine clinics and I was doing all of our COVID testing. And so this was really good experience with working with clinicians and patients and kind of ground in that I wanted to stay in the medical sciences field. But I was definitely more interested in like the medical physics, the imaging side. So I graduated and decided that I really wanted to stay in research. That's kind of all I wanted to do was, do eventually have my own research lab, hopefully teach physics or teach physics, teach medical imaging. And to do that, I knew I needed a PhD, which brought me to UC Berkeley, which is where I am now. And I've been really happy here. Like I said, I work with Dr. Morrison in the radiology department at UCSF. We do a lot of work with movement disorders. Generally, I specifically work with Parkinson's disease and neuromodulation therapies for Parkinson's disease. And that's what I'm going to talk about in the rest of this presentation. So just to give a quick outline, I'm going to go into the background of what is Parkinson's disease, what is deep brain stimulation. I'm going to try to get not too lost in the weeds here, but I do think it's important for later when I'm talking about the models that I'm building that we have like the biology basis so we know what our constraints are and why I'm doing certain things. I'll give the motivation for the project. So those are the constraints and what I'm trying to do, the methods of how I am, reacting to those motivations. This project is kind of in a few different waves. Like I said, it's my full thesis. And so right now we're, partway through. I'll talk about some of the first results that we have and then what are the next steps. So what is Parkinson's disease? Throughout this presentation, I'm going to start calling it PD because it's easier and I'm lazy. PD is a progressive neurodegenerative disorder that's characterized by both physical and functional changes in the brain, and the manifestation of these changes are a host of both motor and non-motor symptoms. Some of the very first symptoms to appear are these non-motor symptoms like issues with your GI system, sleep disturbances, you lose your sense of smell in a lot of cases. And these early symptoms can show up years before any of the motor symptoms are noticeable. As the disease progresses, patients will experience more motor symptoms like tremor and rigidity, which can lead to significant issues with balance and movement. PD is currently the second most common neurodegenerative disorder in the world, and there's millions of people who have PD. There's almost 100,000 new cases every year, and that number is just going to keep growing as the population is aging. So it's important that we are getting ahead of this disease with our research efforts. So I'm gonna start looking at this, like I'm gonna go under the hood and see what is causing these symptoms. PD is characterized by a degeneration of dopaminergic neurons, particularly in the substantia nigra, which results in reduced dopamine production. When the dopamine levels drops, it disrupts the balance of the excitatory and inhibitory signals within the basal ganglia, and this leads to abnormal activity patterns, particularly those that affect the thalamocortical circuit, which connects the thalamus to the motor cortex. In PD, abnormal basal ganglia activity causes irregular signals to be sent through the thalamus. And then when the thalamus is impaired, the motor cortex struggles to coordinate and regulate movements properly. And so this is what results in those hallmark symptoms that we associate with PD. But this isn't the whole story. PD is systematic and it's been linked to widespread changes in the brain. And many of those changes we're actually able to probe with medical imaging non-invasively. And so to quickly go through some of these, there are physical changes that we can see in the brain with medical imaging. One of the key changes we see is the regional atrophy of both cortical and subcortical areas. This widespread atrophy can correlate with both the severity of motor symptoms as well as cognitive decline that's seen in later stages of PD. We also see degeneration of white matter tracts, which are the pathways that connect different regions of the brain. And then finally, we see an accumulation of iron in deep brain structures like the basal ganglia. This iron is thought to contribute to oxidative stress, which further accelerates neurodegeneration and kind of this nasty loop. Um, so we also see functional disruptions along with those physical changes, and we can see these with things like PET, so nuclear medicine, nuclear imaging, or with functional MRI. We see disrupted metabolic activity. In this image, we can see that there was increased metabolism in the dopamine or in the PD group in deep brain structures, but reduced metabolism in cortical regions. Functional MRI has also shown abnormal connectivity between deep brain regions and the motor cortex, suggesting that there's a communication disruption between different brain networks that's impaired in PD. So we have all these new tools that can help us understand what is happening in the disease. But despite that, we still don't have a cure for Parkinson's disease, and all of our treatments are focused on managing the symptoms of the disease. And historically, this was done with invasive approaches like lesioning specific brain regions that would then alleviate symptoms. But with advancements in medicine, right now, the most common approach today is pharmaceutical. And the most common drug is called levodopa. It was introduced in the 60s. It remains the most effective medication for managing motor symptoms. It replenishes the dopamine that's lost due to the degeneration of those neurons. The problem is that as the disease progresses, patients often require higher doses of the medications to achieve the same effect. And over time, the therapeutic window narrows. So the dose that is causing side effects is getting closer and closer to the dose that is actually producing the desired result. This can lead to fluctuations in symptom control, which is known as like on-off phenomenon, where the medication is wearing off more quickly and the patient or the subject is undergoing periods of immobility or having erratic involuntary movement. And so this necessitates the use of an adjunct therapy in addition to the medication, which is where deep brain stimulation comes in. DBS was first used for PD in the late 1980s, and it's since become a really widely adopted treatment for managing the advanced symptoms of PD. The procedure involves implanting electrodes into specific brain regions that are involved in motor control, so like the globus pallidus internus and the subthalamic nucleus. And then the electrodes are connected through a lead that's implanted under the skin to a pulse generator that is surgically implanted in the chest wall usually. And this will deliver electric impulses to the brain. By delivering regular high frequency impulses, DBS can replace the pathological firing, that is the firing patterns, with more organized regular patterns. This helps to restore the flow of information and improves the motor cortex's ability to regulate movement. But the actual story of how DBS works is more interesting than that. Some of the symptoms are affected at different time scales. So like tremor, you'll see results almost immediately when the device is turned on. But then other symptoms like gait and balance could take months sometimes to improve. And so there's different mechanisms at play that aren't totally fully understood yet. But the important thing is that we know that it does work and it's already improved the quality of life for thousands of patients. Specifically, studies have shown that motor symptoms and tremor and rigidity have improved in 70 to 80% of cases, which is really great. But if we turn this around, we can say that actually DBS does not alleviate motor symptoms in 20 to 30% of cases, which doesn't sound as great. DBS is a stressful surgery. It is an open brain, it's an invasive procedure. It involves drilling, boreholes into the skull and inserting these electrodes. And beyond that, the patients are, they get their hopes up that they're going to see improvements. Their families, their caretakers get their hopes up, and then, to not see any improvement, or maybe even things get worse, it can be really disappointing, and affect the mental health of patients. And so it's important that we're making sure we're choosing patients correctly, and that we have an understanding of which factors influence the success or lack thereof of DBS for PD. These factors are, can kind of be broadly lumped into four different areas. The electrode position, so how accurately is the electrode placed into the correct structures that we're trying to stimulate. The stimulation programming, so what frequency, what voltage are those appropriate to actually activate the axons in that area. And then these other ones, the demographics and disease state, these are the ones that are probably more relevant for selecting appropriate candidates for the surgery. Demographics like age and sex could affect how well someone responds to DBS, and then disease state, so that's how long have they had the disease, what's their brain health like, how responsive are they to the levodopa medications. And the brain health in particular is something that we can probe with medical imaging. And it has been done in the past. So far, the efforts to predict or understand outcomes of DBS have been limited and a little bit fragmented. They've focused on correlations between single imaging features using things like diffusion MRI, functional MRI, and quantitative susceptibility mapping. I'm going to briefly touch on these, I think, in the next slide. And they have found actually some really promising results. But where they are lacking, or where I'm going to kind of try to fill the gap, is one, that these are smaller studies. Some of them, like the QSM ones, one of them is 8 subjects. Some of the larger ones are, around 70 subjects, which doesn't let you do a whole lot of like predictive work. And then the maybe more interesting weakness, I think, is that they all look at these features in isolation. And PD and neuromodulation are really complex phenomena. And I think it's not quite accurate to say that we can get a good picture of brain health by just looking at a single feature in isolation. And that we should be looking for a more holistic view that maybe incorporates all of these things. And so that's what I'm going to talk about now, is what kind of information can we get from all of these different imaging or types. I'm not gonna, I know that this is like a group of people who focus on medical imaging, so I'm not going to get too detailed here. Structurally, we can look at like C1 weighted imaging. These are always collected for all DBS cases for treatment planning and staging. We can get detailed structural information, and use features like cortical thickness and fractal dimension that can give us insight into surface complexities, which can offer us interesting insight into the changes in PD and how those would correlate with DBS outcomes. Functional MRI, with its ability to indirectly measure brain activity through blood oxygenation, is incredibly valuable for tracking the dynamic functional aspects of PD. And so we can look at things like connectivity patterns and activation maps to better understand how DBS is affecting brain networks, especially those involved in motor control. Diffusion in MRI sheds light on white matter integrity by measuring the movement of water molecules within the tissue, the like thermal Brownian motion. The direction and diffusion The direction of the diffusion of the water is influenced by the organization and condition of the axons. So diffusion MRI is a good tool for assessing the health of white matter tracts that are involved with motor control, critical for understanding PD and its response to stimulation. The features we're interested in here are like fractal anisotropy, the diffusivity, the comparison of axial versus radial diffusivity. And then finally, quantitative susceptibility mapping. where susceptibility is a measure of how much a substance gets magnetized itself when it's in the presence of a magnetic field. All tissues have different magnetic susceptibilities that end up causing local field homogeneities, and they induce phase shifts in our MR signal that we can track. Iron, which is paramagnetic, has a particularly strong susceptibility compared to other substances in the brain. And in the context of PD, we talked about how iron accumulation in regions like the substantia nigra has been implicated in the neurodegenerative process. We can quantify and map the distribution of iron in these regions, and that can give us some insight into disease progression. So this leads me to my main goal, which is to develop and build a multimodal, multi-contrast imaging model that uses both like imaging and clinical data to assess patient-specific factors that influence DBS outcomes. That allows us to accurately determine which patients are the best candidates for DBS based on their individual neuroanatomy, imaging features, and demographics, with the underlying goal of improving patient selection using robust, interpretable metrics that are derived from their own imaging and clinical profiles. To do this, I have to kind of think about what data do we have available. And so we are in a good position at UCSF, which is one of the largest DBS centers in the world. And we have about 13 years of retrospective data, which gives us a large base to work with. In total, right now, we have about 457 patients in the database, but for the current iteration of this project and some of the results I'm going to be talking about, I was working with 231 patients. This was scaled from that 457 based on who had outcome metrics that we could use and stuff like that, but this is a growing number. And I have binned these for classification tasks into, I'm going to talk about LEDD in the next slide, but this is a measure of how much medication a patient is taking. And so the two bins are going to be either they started taking less medication or they saw no improvements, or even they start taking more medication. So those are my two bins for the classification later. Our cohort includes a mix of subjects who underwent both STN and GPI DBS, and some of them received implants only on one side, so unilateral, while others received bilateral in both hemispheres. And these are all things that were taken into account in our models. Importantly, like I said, we're still continuing to recruit patients and expand our data set, and everything will eventually be pulled into this analysis. So what outcome metric are we using? I mentioned this briefly. LEDD stands for levodopa equivalent daily dose, and this gives us a way to quantify the reduction in medication burden. So it standardizes across the different types of PD medications, maybe the different schedules that people are on, so that we can compare not only between a bunch of different patients, but also in one patient over time and across different conditions like turning on DBS. And so we defined our change in LEDD like this, where it's the pre minus the post divided by the pre, so just like a percent change. And we limited our cohort to people who had medication information from 3 to 24 months after DBS. And we tried to get as close to that 6-month post DBS visit as we could. Because this is a retrospective study and there's like a sporadic nature to the visits and when patients came in and talked to their doctors, we couldn't really standardize further than that unless we really wanted to reduce our cohort size. And so we got as close to 6 months as we could, but there was some variability there. The next thing I had to consider when designing this model was the fact that this is retrospective data and it's clinical, and that makes it inherently messy. And it's one of the major challenges that we face when we work with clinical data. This is when I first started the project and I was looking at our database. We have 457 patients, but only T1 weighted imaging was collected for everybody. Then 51% of those patients had diffusion, 37% had functional MRI, and only 19% had QSM at the time that I was first looking at this data. Um, and traditionally, when you have incomplete data sets like this, there's like two ways to handle this. The first option would be to exclude patients who have incomplete data, and this would ensure clean, complete data sets. It looks really nice. But the problem is that it significantly reduces your cohort size, which can limit your statistical power and could potentially introduce bias. The second approach is typically to interpolate the missing data, which is essentially trying to estimate or guess the missing values based on the information you do have available. And this, in some cases, is a reasonable solution, but it can lead to inaccuracies and to overfitting, because your model would be trained on data that isn't actually reflective of your patient population. And so I didn't want to do either of these things. Um, and I wanted to create a model um, that can use patients regardless of their data availabilities. And the idea is that this model can still process each patient based on whatever data is available. So whether it's just Q1 weighted imaging or some combination of the different modalities. Um, it would allow us to train the model and importantly, make predictions even with incomplete data. And I'll talk a little bit about how I went about this because this is not like a trivial thing. Um, One of the most exciting aspects of this approach is that it gave us the potential to provide a confidence level based on how much information was available. So we would give you a prediction and then how confident are we in that prediction. Um, so now we have all of these different features. We have a bunch of patients, and this leads to a really big high dimensional data set. And whenever we're working with high dimensional data, like we often are in our imaging studies, feature processing, feature selection becomes really important, or else we risk overfitting, where the model is going to perform really well on the training data, but then fails to generalize to the new data, and it becomes too complex and relies on features that don't actually contribute meaningfully to the prediction. So to address this, I used regularization techniques like lasso and ridge to both fit the model and prevent overfitting by controlling the complexity of the model. Lasso regression was particularly powerful because of its L1 penalty, where we are minimizing not just the prediction error, but also the absolute values of the model's coefficients. And this actually forces some of the coefficients to shrink to zero, which effectively removes them from the model if they are not contributing meaningfully. And so this makes it a really robust tool for dimensionality reduction. And we're retaining only the most informative features. So it's simplifying the model while maintaining that accuracy. Ridge regression, on the other hand, applies an L2 penalty, which uses the squares of the coefficients and then shrinks them towards zero without ever fully removing them. And so it's keeping all of the features in the model. For this analysis, what I did is I used the lasso to select the features, do the dimensionality reduction, and then with those selected features, I did a ridge regression and I used the normalized regression coefficients as the weight initialization for my predictive model. So I'm benefiting from the ridge's stabilizing influence while still leveraging lasso for the dimensionality reduction. And then I tuned the shrinkage factor. So how much are we reducing those coefficients um, by an optimization process, trying to make the model as accurate as possible to find the right balance between the model complexity and maintaining predictive performance. And then once we have all those features, how are we actually going to be organizing them and controlling them? And for this, because our data set is high dimensional, complex, incomplete, it's difficult for traditional methods to handle. I propose using hypergraphs to represent and process the data. Hypergraphs move beyond the pairwise comparisons that you get like with traditional graph theory. And so we can capture high order relationships between groups of subjects who have similar characteristics. So when I try to describe hypergraphs to people who aren't familiar with them, I say hypergraphs are like a generalization of graphs in the same way that a rectangle is a generalization of a square, right? So like technically every square is a rectangle, but it doesn't go the other way. And technically every graph is a hypergraph, but it doesn't go the other way. So in a graph, you have nodes and you have edges, and every edge connects exactly two nodes. But in a hypergraph, you have nodes and hyperedges, and every hyperedge can connect any number of nodes. In our study, the nodes represent subjects, and the edges are the relationships between multiple subjects based on shared characteristics, how similar they are in different feature spaces. They are particularly well suited for handling multimodal data because they allow us to integrate information across subjects who have different combinations of available data. And I'll show you kind of under the hood what this looks like from a matrix standpoint. Hypergraphs have become more popular in medical imaging research recently, especially as data sets become more multimodal and complex. They were first used kind of in like social networking advertising the most. And then in the early 2010s, they started gaining some traction in medical imaging. And since then, their usage has steadily grown, and especially in neuroimaging. So let's look a little bit under the hood, like I said. If you're familiar with graphs or working with graphs, you know that the main matrix you're working with is an adjacency matrix. The comparison of that with hypergraphs are incidence matrices, which have the subjects or the nodes as the rows, and then the hyperedges as the columns. And so in this example, you can see that like node 1 and 5 are contained in hyperedge 1. This is a very simplified example. This could be like a binary feature. So maybe the subject had STN DBS and the subject had GPI DBS or something like that. And so each feature would get its own incidence matrix. So this could be, like I said, the target for DBS. This could be, fractal dimension of the frontal lobe, and they are connected based on some threshold of similarity. You would create all of your feature incidence matrix separately, and then once you have them, you would concatenate them horizontally. And so you would take them and you would just like paste them all next to each other because all the rows are exactly the same. And that effectively creates one large multimodal hypergraph that integrates all of the available data. And so for the example of how this lets us include people who don't have all the features, say that someone doesn't have fractal dimension of their frontal lobe for some reason, they would still be in this matrix. They would just have all zeros. They wouldn't be included in any of the hyperedges for this feature, but they would have a bunch of other matrices and features that would give them information for the modeling later. So because each hypergraph is formed in its own feature space based on feature similarity rather than the raw values, we avoid issues with different ranges and values. So like for fractal dimension, the values we're looking at are probably somewhere from like 2 to 2.4, but then if we have age, there's a higher range. And directly inputting those into the model without any adjustment would cause an imbalance with the larger scale features dominating. And so when we use hypergraphs in Sway, we kind of avoid that issue. And so makes it a robust method for multimodal data integration. Once we have our hypergraphs, we can do our classification. And like I said earlier, the classification task that we have been doing so far is between subjects whose medication use went down and subjects whose medication use like didn't go down pretty much. Our classification model is built on hypergraph neural networks, which are good for analyzing complex relationships in multimodal imaging data. Unlike traditional models, the hypergraph neural networks can capture and propagate information not just between the pairs of nodes, but across entire groups of connected nodes or hyperedges. And by leveraging these multi-way connections, the model learns a richer representation of the data and allows us to predict outcomes with more accuracy. So the inputs of these models are hypergraph representations, which encode the relationships between the subjects and the features. and then the classifier labels, which represent our training targets. The model will first transform the data into the spectral domain, where it undergoes a series of convolutional filters that are designed to extract patterns and relationships in the data. These filters are optimized during the training process, and I'm going to really briefly touch on that in the next couple of slides. After the convolutional layers, we are incorporating the confidence layer, which is kind of a new thing. In essence, it is just how confident the model is about each prediction and helps to generalize better even when some data are missing. And then finally, we have our output layer, which combines all of the information to make the final prediction. And the output's not just the label, but also that confidence score that I was saying, which is critical for the interpretability and actual real world clinical use of this tool. Um, so we'll take a moment to briefly look under the hood again, what's happening with these hypergraph structures in our neural networks. To make things clear, I've used a really simplified synthetic example. So with this incidence matrix, this is kind of like a blueprint of our hypergraph. So here we can see that there are 4 subjects or 4 nodes, 1, 2, 3, 4, and there are 3 hyper edges. The first hyper edge contains only nodes 1 and 2. Let's see. And then the second hyperedge contains nodes 2, 3, and 4. And then the third hyperedge is 1 and 4. And then to perform learning on this hypergraph, we would need to capture the geometric information. So how are the vertices and the hyperedges connected? And this is where the hypergraph Laplacian comes in. But before we can compute that, we need 2 important matrices. So first we need the vertex degree matrix, which tells us how many hyperedges each vertex is a part of. And then we need the hyperedge degree matrix, which tells us how many vertices are connected within each hyperedge. Once we have all of this, we can bring everything together into the hypergraph Laplacian, which is dependent on those degree matrices, and this is the H is the incidence matrix. The hypergraph Laplacian is a mathematical representation of the structure of our hypergraph. It combines information from those degree matrices and captures connections between the nodes and the hyperedges. The matrix is crucial because it allows us to encode the relationships in the hypergraph into a format that the neural network can process. Once we have the Laplacian, we can compute its eigenvalues here, which represent like the frequencies of the hypergraph, and the eigenvalues give us a way to understand the structure of the hypergraph in the spectral domain, where we can analyze the patterns of variation across the data. In the context of the hypergraph neural network, the learning process involves designing and optimizing filters in this spectral domain. And during the training, the model learns how to use the Laplacian's eigenvalues to apply the filters, capturing important features and patterns that are relevant to our task. This is done iteratively through those convolutional layers where the signal is transformed and filtered, followed by feed-forward layers that map these process signals to the desired output. And then it's powered by backpropagation, where the model adjusts the filters and waits to minimize the errors in its predictions. And then finally, we have that output layer where we make our classification predictions. The last thing I want to talk about here is just this confidence layer, which is designed to handle the variability in the data availability across subjects by dynamically weighting the predictions based on the completeness. So conceptually, if you're imagining a student taking a test, if the student answers all the questions, we can be pretty confident that their overall score is a good representation of their understanding or their ability. But if for some reason they skip half the questions, or they don't have time to finish them, or something happens and they can't answer all the questions, we're less certain about how their score reflects their actual ability. Similarly, in our hypergraph model, not all subjects have the same answers, which in this case is the data completeness. And some may have full multimodal imaging, while others may be missing 1 or more modalities. And this confidence score will act like an adjustment for these variations. So it takes into account how much data is available for each node. So the number of hyperedges that are connected to the node, and then calculates the confidence of weight based on initialization of a sigmoid function, and then assigns a confidence score to each node. And so you can imagine that someone who has only T1 weighted imaging, maybe the model would predict that they would have a good response to DBS, but they're like 70% sure. And then if we were to somehow get access to functional and diffusion imaging, maybe it just wasn't processed before and we add those into the model. Now the model predicts that they will have a good response, and it's 82% sure now. And this makes it something that's more clinically useful. Like I said, this work has been doing in waves. And so the first part is I was only looking at the structural T1 weighted images. This paper is in peer review right now at Nature Communications. And in this paper, I used the T1s and I calculated fractal dimension, which is a mathematical concept that's like a measure of the boundary complexity and self-similarity of a structure. Essentially, it's quantifying how complex or irregular a structure is across different scales. In the context of the brain, fractal dimension allows us to assess whether the geometric properties of the boundaries, like the gray and white matter interface, the peel surface, how those relate to the neurodegenerative process. I segmented 90 regions in everybody's brain and calculated the fractal dimension based on this box counting method. And so this was a lot of data. This is like a simplified schematic of how the box counting mechanism or algorithm works. I'm not going to get too into that. I verified or validated that fractal dimension is a good biomarker for PD. I grabbed 3 different online sources for healthy control data, and I grabbed 3 sources for Parkinson's disease data. So it wasn't just 1 site or 2 sites, but 6 different sites. And I looked at if there were differences between the healthy controls and the Parkinson's disease patients. And this was in total about 140 patients, so 70 of each group. And I found these cortical and subcortical regions where there were significant differences between the groups. And when I threw this into a classification neural network using the hypergraph, there was an accuracy of about 88% in distinguishing between the groups, and also very good or pretty good sensitivity and specificity. And so this was just a validating that fractal dimension was a good biomarker to use. Then I moved on to looking at fractal dimension to explain variance in the DBS outcomes. And I found 16 regions where the fractal dimension was informative for that difference in DBS response or the changes in medication, along with clinical features of the DBS target, whether it was unilateral or bilateral, the subject's age, and then their response to medications, their motor scores in response to medications before the surgery. And then some of the results, I created 2 models. The first was just those clinical features. And so these are the things that would like traditionally be used for candidate selection. And then I created a combined model where I took all of these and then I added in the fractal dimension features. And you can see that the prediction accuracy improved, as did the sensitivity and specificity. And this is just with 1 feature, so just the structural imaging. We're hopeful that when I've added in all of the other modalities, that this will just improve further. So the phases of the project, like I said, we have the structural, then we're working on diffusion and functional right now, and the magnetic susceptibility, and these will all then eventually be lumped together. These will all involve stages of feature extraction and validating, and then model integration and final optimizing and testing. And then eventually, hopefully, we can wrap all of this up into a actual software tool, and we're going to be getting a lot of clinician input, and then maybe it will generalize across broad neurological disorders at some point. But this is kind of like far future. Don't know if it will be me still doing this, but yeah. And this is my lovely lab. I'm not in this picture because I was out of town, but we're definitely all working on this together, and I'm getting lots and lots of help from everybody.
Great. Let's give Devin a round of applause, a virtual round of applause for a very interesting talk on deep brain stimulation. Thanks, Devin.
Hmm.